Annie, good to see you.
Great to see you.
Thanks for having me. Thanks for hosting us here in your house. It's great to be here. And so, Annie, you've been investing for a long time, and you have seen lots of booms and some bubbles burst. Some people have said that we're actually finally there in healthcare, that this is kind of healthcare's .com boom. Do you believe that? What's going on right now?
Well, I'm not sure .com boom is always has positive connotations. Although I will say, I mean, let's face it, Amazon, Google came out of that. So there were many amazing things that actually were funded during that time. But yeah, I do believe that actually. Anything with digitization right now, we're finding fintech, healthcare, so many industries obviously are being well funded. But I think that the most amazing thing that it is an inflection point for the entire industry, and it's not just about the financings, it's about a market that's ready to accept a different product and think about innovation in a different way. And we weren't there 5 years ago.
So what do you think happened? I mean, it's interesting, you take, some of the stories are clear. Like you take something like telehealth. We've had telehealth for 20 plus years. Before the pandemic, 70% of people had some access to it through their health plan or provider or employer or whatever. Fewer than 10% had ever tried it. And when they tried it, they didn't like it very much. Pandemic hits, everybody's kind of forced to try it. All the experiences get better. And it's not at the pandemic levels that it was at the peak, but it's settling in the kind of 20 to 30%. But that was one very specific inflection point. What is different than it was 5 years ago? Like what has made this happen in your mind?
Well, I think first of all on the digital and telehealth side, massive behavior change, right? So that there is something in terms of inflection point and adding virtual models to the existing models of care. And I think that leads to more home care. It changed really not just the consumer behavior, right, but the physician and provider behavior. So I think people are thinking differently, and it does enable a whole opportunity in home healthcare, which is massive. Like who wants to go into a nursing home? Right after COVID, who wants to be institutionalized? I think that's just a different perspective that I think will let 1,000 flowers bloom. I think the other thing, though, that's really important is this pay-vider model. You know, the combination of payer-provider, whether it's from the payer direction, like a Devoted starting as a Medicare Advantage plan, a MA plan, and then adding sort of a digital version of provider to what they're doing, or from the provider side, where primary care is now owning risk. And that you can see from a Village MD or an Agilon, or an Oak Street. And that it's an incredibly important moment in terms of providers owning risk, because we keep trying to fix things from the payer perspective, and that's not going to work. And if you think about, payers, I mean, it's basically 15% of the cost in healthcare, and provider, the whole care management world is 85% of the cost. So you have to go after the 85% of cost, and you have to think about that. And if providers are not incented to care about cost in a way while they're thinking about quality, then the whole system's broken. And this is a way that you can actually incent providers to care about cost.
Well, I think what's interesting about somebody like Devoted in particular, because so last year we had a conversation with Greg Adams about the same thing. Kaiser Permanente's been doing this for 75 plus years. And we had a conversation about, well, why isn't it spread, right? Why isn't there a Kaiser in every community? And, some of my reflection on that is we've tried. We've been pushing at sort of value and new mechanisms of reimbursement for a long time. We had a PCMH wave. We had an ACO wave. We had all sorts of them. But fundamentally, we were trying to do it on the same supply. And I think when you sit in a hospital boardroom, ultimately, for all good intentions, value will bring down reimbursement, but you still have supply abuse, right? You're still the biggest employer in town. And I think what's so interesting now is that when you take a player like Devoted, that what they're doing is building new kinds of supply, or when you take somebody coming into the home. And so they don't sort of have this mismatch when they get a value-based incentive to say, well, I still need to keep something full, right? I still need to be busy. And I think it'll be interesting to watch. I mean, do you buy that? What do you say to the skeptics that say we've been doing the pay-vider thing for a long time. And
No, we haven't.
Yeah.
I think the reality is in many of the ACO models, if you looked at what didn't work in value-based care, it was driven by ACO models that were driven by healthcare systems, that were mostly driven by hospitals. And the reality is those are cost centers, right? And if you look at every model that's making more money, it's because they've driven activity away from the hospital. And so it really has to be driven from a perspective of more, not always, but more primary care than at the tag end of the model in terms of the inpatient side. And I think that's the difference, is that we finally have some models where people are showing that driven from the primary care side, with primary care, people think of primary care and they only think of what that doctor does in the office, but what the doctor can do, right, is it drives 70% of downstream costs is driven by the primary care doctor. If they're enabled with tools, infrastructure, care managers, they can't do it all themselves, but they can do it as part of as a corporate entity.
Yeah. So, I mean, to that point, so there has been record amounts of money flowing into not just health, but digital health in particular and enablement. And, it feels like 5 years ago we were talking about when we might have another $1 billion healthcare company, and now we seem to have one every week.
That's amazing.
And they're getting valued like software companies. They're getting valued like they're in the business of tools and enablement and platforms, even when they have a lot of people and a lot of physician relationships. Is everything overvalued right now? Is this going to crash? or is healthcare really becoming a software business?
Well, I'd say, to public market versus private market. First of all, I think the public market's actually already adjusted. If you looked at a lot of the public multiples, stock prices, where the peaks were, where they are now, there's been a correction. So we have not had a correction on the private side. And there is usually a lag in that. But I will say there are many reasons that multiples, are still high, that there's enormous value in future companies, and that is one, the TAMs of these markets. A niche market in healthcare is massive, right? So if you get something working, and it's beginning to work at scale, the scale can be absolutely enormous. If you look at our payers, right, UHG, 500, you're talking about a $300 billion market cap. You're talking Humana, $50 billion market cap. So I think the markets are extremely large, and these companies are growing incredibly fast. Right? I mean, they're growing like 300% growth rates. I mean, this is just, a different scale. So I think that's exciting, and I think a number of them, warrant the valuations. I just think the problem in venture in general, and even in the public markets, is healthcare is complicated. You have a lot of new people that have come in. They can't always distinguish what's real from what's not. And so it's like peanut butter spread across the entire industry in terms of like valuation inflation, when the reality is it should just be going to the great companies that can scale.
And you're still investing in the great ones. You don't think
and I'm only investing in the great ones.
It does remind me, it's interesting when you just think about the sort of enormity of healthcare. Farzad Masachari was with us a number of years ago now. Pointed out that if you get 100 doctors in a room, primary care doctors, that represents $1 billion in healthcare spending, right, that they can actually control through downstream referrals. And you do that over and over again. I'm interested as you think about sort of these new players, whether they're in the pay-vider model or they're in a software model. You mentioned they pick niches. Right? And in fact, that's a good business strategy. That's what you want to see as an investor. You want to see focus, and you want to see a market you can really disrupt. It does mean that we don't seem to see innovation in healthcare distributed equally, and that it's actually really hard to truly innovate at scale, and not just kind of replicate some of the issues we've had with health inequity for generations in this country, where your zip code determines your health status because of what's available. What does it take to make this stuff work at scale, and is there anything that's exciting you?
Oh, there's so many.
Just go.
It's unlimited. I can't tell you. But I actually do think that we go where the highest need is, and the highest need is where the highest cost is. And so that does mean you aren't just creating models, like a forward where, that's great for the 1% of the private pay world, right? I think there's special needs plans, dual eligibles, which are Medicaid and Medicare recipients. We're creating these pay-vider models all across these special needs plans. And I think are looking for those, owning those most seriously ill patients, whether they be seriously mentally ill. Like we have 3 companies going after SMI in different ways, and I think that is a problem if you talk to every payer and every provider that nobody has tackled yet.
Yeah.
So
and it's
I
an
think
epidemic.
it's so real. It's such an epidemic. Drug abuse, substance abuse. We have a company focused on that. So I think there are a number, as you say, like very large niches that are about those that are most seriously ill and that can benefit, and do have this model where you're taking risks on a patient population of chronically ill or underserved. We have a company called Main Street Health, which is taking the Village MD provider owning risk model to rural markets.
Oh, interesting.
And nobody's figured that out, and nobody's in these rural markets. And it's really a combination of it's back to the old, who's the local pharmacist, and, a bit of urgent care. There are a few primary care docs in these markets, but you really couldn't build a primary care doc model in these rural markets because there just aren't enough of them that are serving the population well. But you can from the pharmacy and the local, CVS's and Walgreens aren't even there. It's a lot of locally owned pharmacy models. And so like Main Street is actually wanting to sort of own the rural market and take this at-risk model to the individual, and are having great luck with it. So
that's really interesting.
Yeah, it's incredibly exciting because it's very underserved and really needed.
Well, I think particularly in this world when we talk about, all the headlines seem to be about talent shortages.
Yeah.
And we have them. We definitely have them in particular professions. But I think if we're willing to think like that and realize that we have a healthcare workforce that is far bigger than we actually acknowledge a lot of times. I mean, you take somebody like, there's, I think, 65,000 some odd retail pharmacies in the U.S. There's one in almost every town. What can you do with them? Right? How could you use them? What do you do with, other kind of complementary healthcare providers? Right? There's a lot of stuff you can do. So you talk a lot about risk. You're clearly big on sort of alignment of incentives and a business model that involves taking risk. At a certain point, that ends. Right? Just structurally, that ends. So if we get healthcare, and maybe this is the optimist in me, but if you get healthcare where you've taken out most of the waste, the business model has to change. You can't arbitrage a market anymore at that point. Do you worry about that at all, or do you think we have lots of runway?
We have a 20-year runway there.
Okay.
I mean, I think we have a long runway. But we are, we're also backing companies that use robotic process automation. And if you think about staffing shortages, creating efficiencies are absolutely, one way we have to go. Technology really hasn't been used materially in healthcare. And I think there's a long way to go to really leverage the workforce we have and do those simple, repetitive tasks that we can't even find people to do anymore. So it's not about replacing people. It's just about finding efficiencies. And I think, it is amazing. We have added over the last 20 years for every caregiver provider we have brought in, there have been 10 administrative people we've added to the system. So this is not a winning formula for anyone in healthcare.
I mean, it's I think it's actually one of the challenges to change. Healthcare crossed retail 3 or 4 years ago as the biggest employer in the U.S. And so which
is part of the problem and why it's so hard to change.
Well, this is exactly the point. Which is, if you're the biggest employer in town, what are you going to do to take costs down?
Exactly.
Right, without really damaging that town.
Right. It's very hard.
But I think we have. I mean, I would suspect you agree with me that as just underlying healthcare demand increases as we age, you have an opportunity to grow through technology, which starts to address some of that before you really have to look seriously at employment costs differently. So on that note, I've got to ask. If we were sitting here in your living room 5 years ago, we probably wouldn't have been talking about the telehealth boom in the same way, the home health boom in the same way. We didn't even talk about sort of the scientific innovation that has come out of the pandemic. What do you think we'll be talking about in 5 years? Where are you betting?
Where am I betting things are going?
Yeah,
I think that it's really home health. That I think that's the frontier where we're going to see things we've never seen, and I think it includes robotics and sensors and keeping people in their homes. And I do think we joke about nursing homes, which is obviously no joke, given the number of people that passed away in nursing homes this last year. But I think the reality is that it's so much less expensive to keep people in their homes ultimately. People are happier being in their homes. And so the enablement of individuals in their home through technology and through services that use those technologies, that's going to be, I think, the big story. it's going to be very meaningful, I think, to society.
Yeah, I certainly hope so.
Yeah.
We've talked about the kind of power of software and innovation, the power of what I think of as kind of a new kind of value-based reimbursement, new kind of supply, a new kind of primary care. But we sit here in this country with 3,000 plus hospital organizations touching nearly every community.
Right.
At the beginning of the COVID pandemic, we thought we might have a hospital financial crisis. There were some estimates that 1 out of 5 could go under. And in some ways, that could have been a very cleansing, disruptive moment, a difficult one, but one that created a new kind of space.
Right.
That didn't happen. In part, there was federal funding. In part, volume returned actually relatively quickly by kind of July, August of 2020.
Agreed.
But what we now have are hospital systems with overworked caregivers, physicians who aren't sure how much longer they want to practice, but actually reasonably rich coffers who are looking to invest. As you think about the kinds of companies you invest in and this new model of a new kind of supply, new kind of primary care, new kind of digital, how do you think that the health systems, and particularly those that are hospital dominant, need to change in order to be part of that and in order to evolve in the absence of a big financial disruption?
Right. Interesting. No, well, it's all true.
Yeah.
I think the reality is they're moving to more outpatient care. They're thinking about home care. So I think they're thinking about the right things. I just think the problem is that the center of gravity should really come from the other direction in terms of the caregiving world. And I think if you looked at the P&Ls of these hospital systems, still the profitability and the dominant revenues are still inpatient.
The building.
You're right. And everything that we've done, like if you looked at everything we do to create innovation, it is about keeping people out of hospitals. And so the question is, can they get rid of that drug? Do all of these outpatient kinds of facilities, urgent care and others, are they all just, even primary care networks that hospital systems own, are they all just feeders to the hospital? Is that the ultimate goal? Or do they really rethink healthcare? And I don't want to indict all hospital systems, but, it's a very hard, that is the motivator, right? To bring people into the hospital ultimately. So I think that will be the interesting juxtaposition. Like, what's the evolution of these systems in the next 10 years? Can they really think in terms of how do I over a lower cost for the system? And the problem is if we don't move away from fee-for-service, which is the drug we're all on, right? They're all on, then you're going to have a problem. If we can really move to a value-based system that's completely outcome-driven and driven by costs, and there are enough payers and CMS thinks differently about how they pay these healthcare systems, then you're just going to get, it's the definition of insanity. You're just going to get the same thing over and over and over again and increasing costs.
So I talk to a lot of probably the same innovators you do, and one of the questions they inevitably ask is, should we take on the local health systems or work with the local health systems? What do you advise them? Do you advise building around, or do you advise building with?
Depends on enlightened leadership.
Yeah.
I always think that people should go to the boards of these, of these systems and talk to them really about what true innovation means and what cost reduction means, and really getting people to think differently. Because I think it's very hard for a legacy system to think differently, particularly in the not-for-profit world. And when they think they're not-for-profit, but they're really driving for the same bottom line that every for-profit is. So I think it is difficult, and I think it is, as you point out, the largest employer in all these markets. And so we have to create other employers in these markets.
Yeah. Well, I'm saying incentives for disruption in a not-for-profit world. You have a board that literally by definition wants to keep the mission of the place going in perpetuity. Which is very different than maximizing shareholder value. And there's a lot of problems with public companies looking at quarterly earnings and all that. But
I think
it's a different governance.
It's a different
mindset.
Governance, and the question is your responsibility to the community or to the hospital system in that community?
Right.
And I would say, of course, it's to the community. That's who that's who the hospital system is serving. And so that's what they should be thinking
But
about.
man, it's hard to operate that way when.
That's
you and I have been in those boardrooms, and everybody thinks about growth, and they think about the mission of the organization,
yes.
not necessarily the whole community.
Absolutely.
Yeah. So, I mean, on that point, and speaking of kind of governance and leadership, Bernie Banks has spoken with us about how we think about a kind of new kind of leadership, a bolder kind of leadership. My observation is that we have a lot of companies out there trying to disrupt healthcare that on paper look the same and or similar, and that the ones that do well and the ones that don't, the big difference is leadership. Would you agree with that? And what do you look for in leaders?
I absolutely agree, because the most important thing in any one of my companies is the CEO and the team that they recruit. And it almost doesn't matter what the business model is initially. We have to believe in that leader and the team, the type of people they attract. And I think particularly in healthcare, you start with ethics, right? Ethics, morals. What are they in the mission? Yes, they want to make money as an entity, and to be a successful entity, they need to make money. But is their mission really to change things in healthcare and to better people? And if they don't want to, if you don't get a sense that that's their number one mission and goal and raison d'etre, then we're not interested. It's just too fraught. There are too many financial schemes that have happened, in healthcare that we're just not interested in. They have to be that leader that people follow. And we say to be an entrepreneur, you have to be a Pied Piper. The people, you can't lead it, but they have great people following, right? It's just the way the world works. And I think they have to have amazing self-confidence, the confidence to hire the best people, to hire people that are better than they are, to ask questions, not arrogance. That's the worst thing in healthcare or in any company, but really intellectual curiosity, and to the point where they're so confident they will ask any dumb question of anyone, because there is no dumb question, of course. And there's so many new great people that come into healthcare. These entrepreneurs there's so much they don't know. So those are just fundamental characteristics for us in leadership.
Yeah, hear, hear. Annie Lamont, thank you very much. It's a great conversation, and thanks for hosting us
Great
today.
to talk to you, Sam. Appreciate it.